Health Policy. And today you're here for the California Telehealth Policy Coalition's 2024 California Telehealth Policy Coalition legislative briefing, telehealth developments, and opportunities. Next slide, please. Next slide. First off, I want to thank today's sponsor, the California Healthcare Foundation and the Center for Connected Health Policy, for their generous support in doing our educational webinars and our legislative briefings. Without their assistance, these events would not be able to happen. So thank you for their continued support. Next slide, please. A bit of background about the California Telehealth Policy Coalition. The coalition actually was started over a decade ago around the advancement for the Telehealth Development Act of 2011. It began with a small group of statewide organizations that were interested in the progress of that bill. And after that bill was passed and implemented, the group continued to meet and it's grown from there. It started off with a handful of statewide groups, about 5 of them, and now it's grown to about over 150 different groups, both on the statewide and national level. The coalition meets monthly, and we work to look towards advancing telehealth policy in the state of California, as well as providing educational information and materials to the state in general. Next slide. The objectives for today's webinar is to provide you with an overview of recent state legislative developments, discuss how telehealth policy supports specific health needs, and also highlight policy opportunities and stakeholders' perspectives as we go into 2025. Next slide. To kick us off today, we'll get a legislative overview from policy advisor at CCHP, Amy Durbin, followed by a panel discussion that will be moderated by Mike Curlin from MedOne. So without further ado, I will now turn it over to Amy.
Thank you, May, and hello, everyone. Thank you for joining. So I'm just going to start us off by providing a brief overview of this year's telehealth-related legislation that the coalition tracked, as well as other recent updates. So we can go to the next slide. First off, the coalition tracked nearly 20 bills this year, with many falling under the main categories of telehealth and Medi-Cal, licensure, as well as broadband and AI. So as you'll see as we go through them, most did actually not end up passing, with only 2 bills that were related to AI getting a governor's signature. So in terms of Medi-Cal and telehealth, there were 2 bills this year, both of which the coalition supported. AB 1943, which would have required the Department of Healthcare Services, or DHCS, to produce a public report on telehealth access and outcomes in the Medi-Cal program. However, this bill was held in the second house on the Senate Appropriations Committee suspense file. We won't be covering it today, but just a quick note that DHCS did start producing reports on telehealth utilization this year, and a dashboard of that information is available on their website. And then we have AB 2339, which would have allowed asynchronous or store and forward telehealth to establish a patient-provider relationship within the Medi-Cal program if the visit was related to sensitive services, such as services related to behavioral and or reproductive health. We'll be talking about this one more in the next section of the briefing, but just want to briefly highlight for now that the bill was modeled after an existing exception that allows audio only to establish a patient-provider relationship. However, the governor ended up vetoing the bill, with his veto message noting that he believes there are details of a patient's medical history and information best gathered during a synchronous appointment, and that there's consumer protections provided through live interactions. So we'll be discussing this more and whether those points are really accurate based on actual provider patient experiences. And then next up, we have licensure, which this year's legislation focused in on compacts specifically, with AB 2051, which would have entered California into the Psychology Interjurisdictional Compact, or PsyPact, AB 2566, which would have entered California into the Interstate Counseling Compact, and AB 3232, which would have entered California into the Nurse Licensure Compact. The last one was more controversial, so it was never heard in committee. However, the first 2 did make it through the first house, but ultimately were held in the Senate. California is one of the few states with no compacts, although it does have some very limited licensure exceptions. The coalition did do a webinar on licensure a couple months ago that's available on CCHP's website, And we do have staff from Assemblymember Bonta's office who worked on AB 2051 joining us today in our second half of the briefing. So she will be able to get into some of the dynamics at play related to compacts and licensure in California as well. And then on the next slide, we get into some of the broadband access and digital equity legislation. The first two bills the coalition also supported at the beginning of the year when they had the same language, though AB 1588 was amended down the line a couple times to address opposition. So ultimately, prior to it still being held in Senate Appropriations Committee, it looked to expand existing Lifeline programs and providers that offer affordable broadband access. And then SB 1179 was never heard in committee, but it would have required the state to only contract with internet service providers or ISPs offering affordable home internet service. This approach was more controversial and it was never heard in committee. AB 2239 would have defined and prohibited digital discrimination of access. And while making it through the first house, it was ultimately held in Senate Appropriations. And we'll be talking a bit more about some of these broadband and equity bills later on in the briefing as well. In terms of artificial intelligence and the two bills that we were tracking that actually were signed this year, AB 3030 is an AI disclosure bill, and it'll require health facilities, including physician offices and clinics, to include a disclaimer in AI-generated communications with patients. So that might include displaying the disclaimer through chat-based and video communications and at the beginning of audio and written interactions. And then SB 1120 will require insurers using AI in utilization review processes to meet certain requirements to ensure it is more fairly and equitably applied. And then we've got our last couple slides on bills. So most of these were held in appropriations committees, likely due to fiscal concerns and a tough budget year. These first few would have required various departments to create new programs. The first one would have been a grant program aimed at facilitating a telehealth network. The second was focused on a program for the state's regional centers and the use of teledentistry to increase care for people with developmental disabilities. And the last one would have created a pilot program to increase access to mental health and telepsychiatry services at 2 or more Department of Corrections and Rehabilitation institutions. And then on the next slide, we have AB 2246, which sought to explicitly include qualified autism service paraprofessionals under the definition of healthcare provider within the existing telehealth statute. AB 2775, which would have authorized the Emergency Medical Services Authority to develop guidelines for the use of telehealth and collection of telehealth use information. And AB 2058 actually did make it to the governor, but it was vetoed because the message said it was unclear what devices the bill was actually capturing, since it would have applied to non-federally regulated devices that collect information such as heartbeat, blood pressure, body temperature, and it would have required a disclosure that the devices may have limitations impacting its effectiveness for certain populations. And then AB 2200 was this year's single payer bill, but it also required provider data collection, including regarding health information technology and artificial intelligence, and it was held in fiscal committee in the first house. And so on the next slide, we're going to get into just a couple more policy updates from this year outside of bills. So while these concepts were not necessarily new, as they were contained in previous legislation that adopted much of Medi-Cal's existing telehealth policies, SB 184 from 2022, and then AB 1241 in 2023 that tweaked a piece of SB 184, the policies did not go into effect until this year upon being published in the Medi-Cal Telehealth Provider Manual in March. So the two new telehealth provider requirements in the Medi-Cal program, and we note that similar requirements do not exist in private payer laws, so this is specific to just Medi-Cal providers, are related to patient choice and ensuring a right to in-person services. So the first, related to patient choice, requires providers offering audio-only services to also offer video services. Although there is an exemption if the provider does not have access to broadband, If claiming that exemption, DHCF states that providers must maintain supporting documentation that might be requested by DHCS. And then the second requirement requires that telehealth providers also provide in-person services or facilitate access to in-person services through a documented referral process, though that provider is not required to schedule the appointment on behalf of the patient. And so that was the policy overview, but if we go to the next slide, before I turn it over to Mike to start our panel discussions, I did just want to go over this background slide really quick. So our next panel is going to be discussing asynchronous telehealth policies in Medi-Cal, tying back to AB 2339 from earlier, but we wanted to give a little context first in that generally Medi-Cal does not allow a new patient-provider relationship to be established via any modality that is not live video. However, there are some existing exceptions. I mentioned before that there's an existing exception for audio only establishment for sensitive services, which AB 2339 was modeled after, but there are also additional exceptions already in place for asynchronous establishment as well, though they only apply to FQHC, RHC, and teledentistry, and some of that exception and criteria can be seen on the slide. And again, we note that these policies are specific to Medi-Cal and do not similarly exist in private payer laws, which can create additional confusion and access gaps. But I'll now turn it over to Mike to get into the discussion on remaining policy gaps, which will be followed by a discussion on future policy opportunities as well. So allow me to introduce Mike Kurland, Vice President of Clinical Quality and Integration at MedWand, one of our committee co-chairs and our gracious moderator for today's briefing. Mike.
Thank you, Amy. Hello, everyone. Just a reminder that the slides and the recording will be available, and to please use the question and answer aspect of Zoom. We'll get to all of them as much as we can. Just a little bit about me. I've been a proud member of the California Telehealth Policy Coalition for over 5 years and serve as the co-chair of the Education Committee. I've also had the opportunity to serve in similar roles in Pennsylvania and Delaware. Today's a real treat, I think, for the audience and myself. We're going to hear from a dedicated group of experts as we explore a range of important topics, including asynchronous telehealth, licensure compacts, broadband, and, to everyone's surprise, AI. To get us started, I'd like to introduce our first two speakers, Kelby Lind from Planned Parenthood Affiliates of California, and Dr. Paul Glassman from California North State University. Kelby and Dr. Glassman, please take a moment to provide a little bit about yourselves, and we'll dive right in right after.
Thanks, Mike. Good afternoon, everybody. My name is Kelby Lind. I am the Vice President of Regulatory Affairs at Planned Parenthood Affiliates of California, also known as PPAC. And we are the Policy and Legislative Advocacy Office representing California's 7 independent affiliates who collectively operate more than 100 health centers throughout the state. We serve more than 700,000 patients annually, and among those, 85% depend on some form of a Medicaid program.
And Dr. Glassman.
Yeah, thank you. I'm a professor and associate dean for research and community engagement at California North State University College of Dental Medicine. And among other things, I'm the current chair of it's called the Partnership for Oral Health, which is a statewide coalition that's working with the Office of Oral Health in the Department of Public Health to support California's oral health plan. And I've been a proud member of the Center for Connected Health Policy's Telehealth Coalition since its inception.
Yeah, I remember my first meeting, you were there.
Okay. I feel like I've been there forever.
Many years ago, yes. Yeah. Well, let's get kicked off with Kelby. And by the way, thank you for all your years of service, Dr. Glassman. Kelby, can you provide us a bit of an overview of 2339, the problem it was trying to solve, and your thoughts about the veto and any kind of concerns?
Absolutely. Thanks, Mike. So Planned Parenthood, like many other providers during the early days of the COVID-19 pandemic, we moved really quickly to implement telehealth policies to maintain access for our patients. And our patients were very quick to adapt to telehealth and even express appreciation for the increased flexibility and access it provided. So when it was announced that the COVID-19 emergency regulations were set to expire, it was important to us that we join other organizations as a co-sponsor of AB 32 a few years ago, which was ended up being a 2-year bill, but was successful in securing permanent payment parity and created that flexibility for new patients to be established at a Planned Parenthood through synchronous telehealth, including audio only. That said, that was not actually our first foray into telehealth. For many years prior, we have had an app called PP Direct, an asynchronous telehealth application that offers birth control, emergency contraception, and UTI treatment. However, we are unable to offer this to our Medi-Cal patients due to the state's limitations in its policy. The Medi-Cal policy states that consultations via asynchronous electronic transmission initiated directly by patients, including through mobile phone applications, are not covered under this policy. Which begs the question, what healthcare is not initiated by patients, and how does one differentiate a patient interaction through a mobile phone application as opposed to, say, a website-based patient portal? Because on the back end, it's often the same thing. When we sought clarification from the department and specifically went over PP Direct and how important it was for patients to access services, they declined to modify the policy and confirm that from their view, PP Direct services were not covered for Medi-Cal patients. We weren't able to get an explanation as to why this limitation exists. It goes beyond anything that we've been able to find in statute. And all of this is what led to our sponsored bill AB 2339, authored by Assemblymember Aguiar Curry, who was our previous champion for AB 32. AB 2339 would specifically clarify in statute that patients could initiate care via asynchronous telehealth for sensitive services, such as family planning, and including through mobile phone applications. It was really directly geared towards that one policy limitation. And it was determined by the state that there was no cost to the bill because it was simply expanding a method by which patients could access care. It wasn't necessarily increasing, who was seeking care in the first place, just how they were seeking care. And this was in line with, the results we saw from the expansion of synchronous telehealth. Unfortunately, despite making it to the governor's desk, we were deeply disappointed to see that Governor Newsom vetoed the bill with the accompanying message, which I think was shared on a slide earlier, but I'll just read. There are details of a patient's medical history and personal health information that are best gathered during a synchronous appointment. For example, this bill would allow a patient to receive treatment and medications for reproductive and behavioral health services without ever seeing or talking directly to a provider. I believe that there are consumer protections provided through a live interaction between a patient and provider. As I said, this message was really disappointing and is not based in evidence. However, it is consistent with previous messages that we have seen from the Department of Healthcare Services. And we previously had to fight the department when we were running AB 32 for synchronous telehealth coverage. They had the same kind of concerns. And ultimately, within the last year, actually, the department published findings from the expansion of telehealth that it expanded access to care and improved, health quality outcomes without necessarily increasing cost or utilization, which is what we were telling them from the get-go. So it was frustrating to see them continue to have these views when it comes to asynchronous as well, because that's what this is ultimately about for our patients who rely on Medi-Cal, ensuring that they have the same opportunities to access healthcare services that folks in private insurance or who can afford self-pay are able to access things. Folks who may not be able to make it to an in-person appointment with other things going on in their life, or who may not be able to do a synchronous telehealth visit because of technology limitations or privacy concerns. So all of that said, we intend to continue fighting for ensuring that asynchronous telehealth is actually in practice covered for Medi-Cal patients. I just don't know exactly what form that will be going forward, as we're, have to reassess things given the veto message. But, there's only growing evidence on the quality of care that's offered via telehealth, including asynchronous modality. And so we think that ultimately we hope to be successful.
I hope so too. The folks here in California and on the team will certainly be following your efforts and want to learn from that as well and share it with the community. Dr. Glassman, you've got quite an extensive understanding of telehealth and in particular asynchronous telehealth. Could you provide some background on asynchronous exemptions for dental care and your reflections on the impact of policy change and any potential for future changes?
Yes, absolutely. So I think I'm going to try to expand on what Kelby has said and also what Amy highlighted in terms of the uneven policy environment we have now in California, particularly around asynchronous telehealth. So
Please do.
let me do this by making 3.5 points. I'll talk about the half at the end. That's just easier to keep people interested. But point number one is that there are many ways that telehealth technologies can be used for the purpose of enhancing healthcare, public health, and health education. And sometimes these are for people who aren't that familiar, categorized into various modalities. So synchronous, we've already been using that word, but to make sure everyone knows what it means, that's talking about real-time video or audio or both. And asynchronous is not real-time, so typically remote record review. Sometimes people talk about other categories, remote patient monitoring, or mHealth, or mobile health, or cell phone health, but those can be either synchronous or asynchronous. So the main divisions are between real-time and not real-time. But actually, it's even more complicated than that, because synchronous interactions can be a patient to a provider. That's what most people think about. You have a physician or a dentist, and they're talking to a patient over a video system. But you can also have real-time provider-to-provider consultation with or without the patient being present. In a consultation mode. You can have asynchronous, can be a patient to provider, where a patient can send some records, photographs of a skin lesion or a broken tooth, and send it to a provider. That's patient to provider. You can have provider to provider asynchronous, where providers are sharing records, or you can have provider to provider interactions where somebody like allied health personnel are at an originating site where the patient is, and they're capturing records and sending it to a provider at what's called the distant site where the provider is. So the point of that is there's lots of different ways that telehealth can be used. And I think there's an assumption, and I think an unwarranted assumption among many people, that synchronous real-time provider interactions are the best way to use telehealth, and they should be supported while other modalities are less useful or valid. That's an underlying assumption. You see it in lots of places. I was on a recent health affairs briefing. Mei Kwong was actually a speaker on that briefing a couple of weeks ago. And I know of those of you who saw it, this wasn't part of May's presentation, but some of the other presenters were presenting on data about the use of telehealth. The data was almost entirely about real-time physician to patient interactions. There was almost no mention of all the other ways that telehealth can be used. So sort of underlying assumption when they were giving a briefing on telehealth was that real-time synchronous interactions, that was what telehealth was. And then also, as we've already seen in the slide that Amy had, in California Medi-Cal policies, synchronous real-time video is far better supported than other methods of using telehealth. So point number one is that there's an underlying assumption among many people that real-time video interactions are the best use of telehealth, and that they're supported in ways that other methods are not. Okay, point number two, we have ample evidence, at least in my field, which is oral health, that asynchronous record reviews can produce great outcomes, and in many cases, even better outcomes than can be produced by real-time synchronous interaction. So I want to give you a couple examples of that. One is a system I've been working on for really over 2 decades now. We call it the virtual dental home system. This is something we performed large demonstrations almost 20 years ago, 13 communities, 50 sites across California, serving 3,500 patients, majority of which were low-income children who typically get no care or only episodic care. And that's because of the many challenges these families face finding access and sources of care. And so that situation results in many of these low-income children ending up with toothaches in school, not learning, ending up in the emergency room, ending up in the hospital operating room. In this system that we're using, the virtual dental home system, we have hygienists and dental assistants that are in preschools or schools in telehealth technology. That's the originating site. And they collect full dental records, x-rays, photographs, charting, health histories, consent, everything you'd expect to have in a fully populated electronic dental record system that you might find in a dental office. Then a remote dentist, again, telehealth language, that's the provider at the distant site, is able to perform an asynchronous record review, complete a full examination, and determine what preventive and early intervention, other treatment could be formed at the school versus what kind of treatment needs to be performed in the more complicated, sophisticated dental office. And we have many modern, which I don't have time to go into now, materials and methods available in the world of oral health. We've been able to determine by this demonstration and others that 80 to 85% of low-income children can be kept healthy at school without needing to make a trip to a dental office. I just want to say that again, because I think it's an astounding and important result for people to really digest. 80 to 85% of children who normally get no care and end up with all kinds of significant problems can be kept healthy at school without needing to make a trip to a dental office because of this asynchronous telehealth team approach that we've been able to demonstrate. So in recent years, after many conversations and meetings, and sounds like maybe our conversations have been a little more successful than yours were, Kelby, but after many meetings, the Department of Healthcare Services actually has supported legislation and regulations that allow dental care providers, as you saw in Amy's slide, to, number one, establish a patient as their patient using asynchronous record review, and number two, perform dental care using this idea of geographically distributed teams that are connected using asynchronous telehealth systems. So this system has started here in California. It's now being replicated actually across the country from states in Maine to Hawaii. And as you saw, this is not the case with other aspects of healthcare in the Medi-Cal program, which continue to support synchronous real-time interactions, but not necessarily asynchronous. All right, so that's one example. A second example quickly is that California has a mandated oral health screening established in 2005, so almost 20 years ago, that requires every child to have an oral health screening before they start school. And the general idea is to identify disease so you can support referral and get people into care. Most schools don't do it. In fact, the data in California is only about a third of children in California have this mandated screening done. And the reason is that it's required that it be done in person by an oral health professional. And most schools can't find oral health professionals to do it. So you have a mandate for a good reason, could do a lot of good, but pretty much is not being effective because it just can't get done the way it's currently set up. So we have just recently completed a demonstration of using school staff to collect records and photographs of children that can be reviewed by a remote dentist using asynchronous record system. And the results of the demonstration show that the remote dentist, by reviewing these records collected by on-site school personnel, could perform the assessment with the same degree of accuracy as on-site hygienists, and in some cases even better accuracy. And better accuracy is because they had more time to actually review the records. They could take these photographs, blow them up, look at them in great detail. And in a number of cases, they actually detected conditions that were not detected in the brief in-person on-site examination. So it's very clear that this is actually a system that could reach more people. It could actually do a better job of this 20-year-old mandate that's not being carried out very well. And it has huge potential to reach the vast majority of children to have this assessment and support them in having early care and reducing the significant societal and personal consequences of untreated disease. So we're currently working with multiple advocacy organizations to establish a way to support this mechanism, both in support of able to do it and payment mechanisms to allow this to be used across California. So point number two is that there's now extensive experience and multiple examples, particularly in the area of oral health, that demonstrates that systems that use allied personnel in convenient locations, communicating with remote providers using asynchronous telehealth, can produce significant improvements in oral health. Okay, point number three. There are several, I think, critical conclusions from all the things I've just talked about that are worth just highlighting. So one critical lesson is that, related to the idea, is that providers have to have enough information about a patient's condition to decide what the condition is and what treatment needs to be done. The assumption that providers will have the needed information using synchronous telehealth, but not asynchronous telehealth, is just completely unwarranted. The amount of information that they have and the amount of information that they need is dependent on many factors, including the kinds of records that are being collected, who collects the records, patient's condition, the potential next steps. And it is absolutely the responsibility of the licensed provider to determine if they have enough information. If they do not, it's their responsibility to gather the additional information we need. It's really impossible to regulate the amount of information that's collected or what information needs to be collected for a particular condition or situation. I mean, you could write an encyclopedia if you were to try to do that. And this is true whether we're talking about in-person care or remote care. So point number 3 is that there's ample evidence that in many situations and for many conditions, asynchronous telehealth can allow providers to collect and have the same level, and in some cases, a higher level of information that then can be available in synchronous telehealth technologies. And so finally, point number 3.5, and this is actually just
This
my
is the
take.
half. I've been waiting for this.
I know. See, it worked. I got your attention. So this is actually just my summary and conclusions, very short, which is that I just want to, yeah, I want to urge the audience to wherever you have the opportunity to support the adoption of laws and regulations, to support the expansion of healthcare using telehealth technologies without favoring one modality over another. It's very clear now that healthcare systems that use asynchronous technologies can result in many benefits that include reaching people that do not normally have adequate care, identifying and providing services earlier in the disease process, lowering downstream costs, using our healthcare workforce more appropriately, and using our complex and expensive healthcare resources more appropriately, and actually the bottom line, buying more health per dollar that we're spending than we do in current systems of care. So thanks again for the opportunity to present these ideas.
Thanks, Dr. Glassman, a true pioneer in teledental and telehealth in general. It's amazing to think that we have a mandate to complete these assessments and that we don't have enough personnel to do that. Asynchronous certainly does offer, from your research, the efficiency and efficacy aspect. So it meets it. So hopefully all this information coalesces into the to the brains and the folks of the people that are trying to make policy change. So Kelby, how do we best support Medi-Cal patients and providers in accessing care for sensitive services like reproductive health?
Well, ensuring that they have access through the modality of their choice would be key there. I think it's important to recognize, especially for sensitive services, that patients don't always feel comfortable going to whoever might be their assigned provider, and there are existing laws in California that allow patients to choose to go even outside of their managed care providers network to a provider of their choice. But in order to establish care with that provider, there have to be policies that allow that. And so that was really important with synchronous telehealth, and we've seen a lot of patients utilizing that to establish care with us, but we need to ensure that that same flexibility applies to asynchronous care.
Yeah, reminding folks it did take a pandemic to really sink in that telemedicine is an option. And there were decades of work leading up to that really happened at a snail's pace until something so significant happened. So hopefully that was really the tipping point, and we'll support the work that you're helping. Dr. Glassman, how can providers, health plans, advocates contribute to building the evidence base for the value of asynchronous care? Now, basically, and if you have any more information about the research and what it's telling us about asynchronous care, please do share that.
Yeah, well, I think in response to the question, what I did want to emphasize is this idea of research. And this is actually something I've been doing for many years in my career, is following a process of using community-based research to advance policy. Obviously, in a university environment, people do research for all kinds of things, and sometimes it's very basic research that may have some application way down the road. I work at the other end of the spectrum, where I'm trying to work on the ground research and community-based demonstrations that actually can directly affect policy. So I think we've actually had a good track record with that. The virtual dental home demonstration that I just mentioned, actually at the end of that demonstration, we were able to use that to change the scope of practice of dental hygienists that allowed them to do some of the things that they're doing in that demonstration, which they could not previously do independently, and now they can, to facilitate this use of asynchronous care. We have another demonstration that's currently underway now in Southern California, where we're showing the ability of home visitors to act at the front end of a dental care system. And this means, again, it's going along with the theme of getting beyond the idea that all healthcare has to be done by licensed professionals. There's lots of other people who are much more in touch with the populations that are not being reached by our healthcare systems, that if we can bring them into I'm using the term concentric circles model of care, where you have, sort of the high cost, high touch, high tech offices and clinics and hospitals. But beyond that, you have virtual care in the community being done by professionals. And beyond that, you have virtual care being done in the community by non-professionals. So the idea of the kindergarten oral health assessment asynchronous record review system was an example of that. And so I think we just need to continue to do more of that stuff. We need to be able to use those kinds of demonstrations to raise awareness, to attract attention among policymakers that it's actually possible to reach many more people, to realize all the benefits I listed a few minutes ago. And at least I know in the work I've been doing, have a track record of that kind of demonstration leading to evidence, leading to awareness actually does make a difference, and you can move the needle forward if you're careful and deliberate about that kind of approach.
Thank you. I have just kind of one more question for you guys before we transition to the next panel. Are there other gaps you believe exist between Medi-Cal and commercial plans currently, like other requirements specific to telehealth and Medi-Cal implemented this year that don't necessarily apply to the commercial plans, and its impact and the confusion that it may cause, for instance? Who wants to go first?
Kelby?
Or
well, if you want.
I was gonna say, I've gone first a couple times, though, if you want to jump in, Dr. Glassman.
Well, what I'll say just about that contrast between public payers, in this case, we're talking about Medi-Cal versus private payers, commercial plans, is that at least in my experience, the commercial plans tend to have far fewer rules, and that can be both positive and negative. Sometimes it can be positive because you can do some things that might be restricted in our Medi-Cal programs. It can be negative because sometimes it's unclear what you can do and what you can't. And sometimes you don't know that until somebody submits a claim and it gets denied. So I think that we have work to do both in the commercial world and in the public payer world to both clarify, have commercial payers do a better job of clarifying what their policies actually are, because that's not always clear. And then obviously in the Medi-Cal world, we've been talking about being less restrictive for some of the things that we've just mentioned, particularly when the restrictions have no scientific or evidence basis and actually restrict the use of effective systems.
Thank you,
I think
Dr.
another
Glassman.
example of where there are differentiations, especially that were implemented this year, the department implemented a requirement that if you are offering telehealth services, either synchronous modality, whether that's with video or audio only, you have to offer the other modality as well. And that doesn't extend to asynchronous. You just have to offer both forms of synchronous telehealth or none at all, which we had concerns about because not all providers have the resources to adopt both, especially at the same time. And especially for providers that have a high Medi-Cal volume and therefore are subject to Medi-Cal reimbursement rates, which may not, be enough to cover those costs. And that's ultimately where there continues to be disparities between Medi-Cal and commercial, as well as how we're paying providers for the same service, as well as a requirement to ensure that patients have access to in-person services, which we completely support, but implementing policies that put certain expectations on providers for how that patient connects to in-person services, if that's what they want. And if a provider isn't able to offer that themselves, then they need to facilitate that handoff to another provider elsewhere. That requires a whole nother level of setting up relationships with other providers in the community. And all of these requirements, while well-intended, can have a dampening effect on the adoption of telehealth, which then has a dampening effect on ensuring that Medi-Cal patients will have these same modes of access as commercial patients.
Thank you. I want to let first of all, thank you again for sharing your perspectives, and I want to let the audience know that We're going to have a chance to like ask questions to the entire panel at the end, and there are a few questions coming in. I really appreciate that. So keep the questions coming. We're going to transition over to the next panel, and we're going to make sure that we have enough time to address the questions that everyone has. I'd like to introduce Natalie Pita, Assembly Member from Assemblymember Bonta's office, and Shirley Lamb from ITUP. If you can, guys, just provide a quick overview of yourselves, so like a quick background. I kind of like blurred a bunch of words together there, but I think you know what I mean.
Yeah, hi everyone. Thanks for having me. Natalie Pita. I am a legislative assistant with Assemblymember Mia Bonta, and I was able to staff AB 2051 this last year, which was the SIPACT compact legislation.
Thanks, Natalie. Hi, everyone. Good afternoon. My name is Shirley Lamb, and I'm the Assistant Director of Policy for Insure the Uninsured Project, or as we commonly refer to ourselves as ITUP. So, for those of you who are not familiar with us, we're a 28-year-old health policy nonprofit and convener with experience creating innovative policy solutions to challenges of access, equity, and quality in healthcare so that all Californians can thrive in health and wellness. We do a lot of different things, but we publish a lot of high-level, in-depth policy issue briefs, blogs, policy toolkits, and fact sheets, as well as hosting a variety of convenings, including our annual conference, policy forums, webinars, and our regional equity collaborative spanning all across California. So thanks for having us.
Well, thanks for joining, and I'll plug in for ITUP. A lot of great resources there. Why don't we put their website into the chat? It's a great source of a lot of really good information. You could download it. I've done it quite a few times. So Natalie, you provide like a quick overview of AB 2051, the problem it was trying to solve, and any issues that arose during consideration and outcome from this year's session, as well as kind of like the future outlook.
Yeah, definitely. So I did prepare a few slides if that's helpful. But basically, AB 2051 was based on my experience and as well as some of my classmates' experiences in college and in grad school. A lot of us moved out of state and we're no longer able to continue seeing our providers. So that is actually when I first heard about SIPACT, because one of my therapist at the time was asking if California was a part of it, and obviously we were not. So I ended up having to stop seeing her. So I looked into SIPACT and was really fascinated by it and brought it to the member, and it was something she was interested in because she's very interested in workforce diversity and also increasing access to the mental health care workforce. So she agreed to author it, and it was a good experience. I think I was met with more challenges than I initially thought. I thought it was going to be pretty unproblematic, but obviously California is not part of any compacts. So, I kind of figured there would have to be a reason for that. So if we can go to the next slide. This is just an overview on occupational licensure compacts. SIPACT is one of many. So currently there's 15 different occupational licensure compacts. The Department of Defense is actually partnering with the Council of State Governments to fund and support the development of new compacts. And this is because it really helps members of the military and military spouses who often have to relocate due to military orders. So for any more information on compacts more generally, I really recommend the Council of State Governments website, so you can access information on all those different compacts. You can go to the next one. So SIPACT is specifically an occupational licensure compact for psychologists, and it allows for the practice of telepsychology and temporary in-person psychology across state boundaries. Currently, 42 states and territories have enacted SIPACT legislation, which means if practitioners in those states apply for what's called an authority to practice interjurisdictional psychology, they can practice and see patients in other SIPACT states. So SIPACT's been around since 2014. but it didn't become active until 2016 when Arizona adopted, they were the first state to adopt SIPACT legislation, and then it became fully operational in 2019 when 7 states had joined. During COVID is when most states started enacting SIPACT legislation. So it went from that 7 to 42 pretty quickly. SIPACT Commission is sort of the governing body of SIPACT. So once a state joins SIPACT, they get 1 representative to be part of the commission. And then this commission comes up with the bylaws and rules and regulations, and also facilitates the sort of distribution of these APITs and these e-passports, which is what is used to make sure that these providers meet set standards, and then also to track sort of how many patients they're seeing in other states. And we can go to the next one. So I started off thinking that SIPACT would be relatively unproblematic. I knew that there were already sort of providers already doing this. So I kind of was like, this is a no-brainer, and at least it'll give some sort of regulatory capability to the California board to at least know who was practicing using telehealth in our state. First, we had some labor concerns. So there are quite a few psychologists who work for state or local government. And the concern there was that if we join SIPACT, their jobs might be contracted out, maybe at a lower rate, because generally people in California do get paid a little bit more than in other states because of the cost of living. So that was something that we ran into. Also just worrying about increased competition. Is there going to be a huge influx of psychologists competing for the same patients? And then the other thing was, one of these standards that SIPACT has set is that in order to practice through SIPACT, you have to have attended an APA accredited school. In California, we have, I think, 6 or 7 schools that are not APA accredited. They are regionally accredited. And other states have this as well, but those providers would be able to practice in California, but would not be able to practice through SIPACT. So there was an equity concern there. And then in terms of sort of concerns that we got from the Board of Psychology was opposed to the legislation. They were sort of worried about ceding regulatory authority to this SIPACT commission, where California would only get 1 representative, and we also have the most psychologists in the country. So was that representation sort of fair? Also, California requires psychologists to take a law and ethics examination based on California laws before they can practice. This, teaches about things like California has a law where it's illegal to practice conversion therapy here. Other states don't have that. How are providers practicing here going to know about these laws if they don't have to take this examination or classes on this? There's also different professional development requirements that California requires for psychologists to continue in education requirements every year to keep their license. Also just worries about patient protection, given that there are different scope of practice laws, there are different sort of standards of care here. And then they are also concerned about the APA accreditation standard because they are concerned about their providers sort of being able to benefit from this as well as providers in other states. We don't have to go into next steps. I know that's something that's going to be talked about later. So I'll pass it to Shirley.
Sure. Yeah, right before we pass it to Shirley, it's interesting that one of the challenges that comes up, and I hear this often, is increased competition. And like growing up, I always learned that competition is good because it makes everyone better. And the fact that we're kind of using increased competition in this state, it's kind of changing the idea of competition. Competition's only good if it doesn't get in your way. So competition is really good for the consumer, though. It's if we have these professionals of every level and every different kind competing for the consumer, I think we're going to all have a better experience. And it's interesting that that's still included. Shirley, can you provide an overview of how ITUP views broadband as a key to access telehealth? as well as AI and telehealth and any kind of considerations
Yeah,
that we
absolutely.
should think of.
Yeah, absolutely, Mike. Thanks for the question. So just some context, like ITEP has 3 key focus areas: coverage and access, in keeping with our original goal of ensuring the uninsured. And that's kind of where broadband, telehealth, and AI kind of intersect in that area. So in alignment with our key focus areas, for the past 3 years, ITEP has been extremely focused on broadband with the goal in mind of achieving an equitable and accessible health system by closing that digital divide. So at the onset of the COVID-19 pandemic, at a time when physical distancing was the most effective way to mitigate the spread of the virus, non-critical healthcare turned entirely online for all Californians. For California's safety net population, this was the first time, thanks to the pandemic permitted policy changes, that telehealth was a major accessible healthcare delivery tool. The necessity of virtual care also magnified that many individuals and communities across the state that persistently lacked access to healthcare were at most risk for COVID-19. They also lacked access to reliable, sufficient, and affordable internet or broadband connectivity. So effectively rendering telehealth services inaccessible to those that needed them most. So as healthcare continues to become increasingly reliant on technology, broadband is the nexus in making the future of healthcare equitable and accessible for communities historically lacking access to care. So for ITEP, we truly believe that broadband is a super determinant of health. We've heard the term social determinants of health, but broadband continues to be at every intersection, whether it's applying for jobs, education, access to healthcare. Everything right now is like looped in with technology. And if Californians don't have access to internet, and that is more than just having your phone in hand, it's having a laptop, knowing how to use it, and all those components. So like I mentioned before, telehealth is a real and tangible permanent healthcare delivery tool, thanks to the approved flexibilities such as payment parity and both audio and video modalities that extended the reach of care to low-income Californians. Broadband unlocks a lot of things, not just the use of telehealth for folks that are served by Medi-Cal, but also innovations in data exchange, innovations in health technology, using artificial intelligence or AI, and machine learning to better health outcomes. Broadband holds all the capabilities to unlock that potential, and we have a collective responsibility to truly break down digital barriers to health. So specifically in regards to AI, it's kind of a new frontier for ITEP. We've explored it this past year. We created a policy toolkit, a fact sheet on it, hosted a webinar as well. But ITEP believes that AI plays a crucial role in streamlining the healthcare delivery system. AI algorithms can analyze individual patient data to personalize treatments and interventions, provide patients with quick answers to basic health questions, and assist providers by scribing appointment notes. Then telehealth platforms and AI-powered diagnostics can improve access to healthcare services, especially in underserved or remote areas where healthcare infrastructure is limited, thus bridging the gap in healthcare access and reducing health disparities. However, AI has that potential to improve healthcare access. Deployment of those AI technologies must consider the affordability and accessibility for user component, especially in historically disadvantaged communities where access to technology and digital literacy may be limited. So hopefully that was a good high-level overview.
Yeah, thank you. I had never heard the term super determinant of health. And like the more I think about it, broadband, it really is. Like could you imagine just like for a day without just our operationally, like what we do as professionals without the connectivity that we have now? Could you imagine to layer on top of that a clinical or healthcare issue that you're trying to address? So whatever challenges that we have now, they just get exacerbated because you have no connectivity or not enough connectivity. So thank you for that, Shirley. Natalie, is your office considering like future opportunities to support licensure, like reform in California? And also, do you think that like there's other licensure policy areas that become more of a focus moving forward for your office?
Yeah, definitely. This is something we're actively researching right now. Obviously, the new session is going to start in January. So I'm not sure on timing, but something that I'm actively looking into right now is reciprocity agreements in lieu of compacts. And to do that, you have to do something which is called like setting equivalency standards. So if this provider is not going to go through the California licensure process, can we make a set of rules that ensure that they are qualified to see California patients? You know, that's probably not going to be up for me to decide, but seeing who needs to be a part of that conversation and if that's something we can pursue in the mental health space, because you know it's not just psychologists, it's also clinical counselors, it's also social workers who provide therapy to a lot of Californians. So that's something I'm looking into right now. In terms of compacts and revisiting compacts, I think that's going to have to be on hold for a while, and I'm just speaking for myself. Just I don't want to run a bill again that we know that the outcome is going to be. So I think that's a broader discussion that needs to happen at the state level, and not just surrounding one compact, maybe surrounding all compacts. And if we can just have sort of this blanket response. So maybe, you know, there could be an opportunity to run legislation that studies compacts more in depth and identifies sort of data that we need before we enter into these agreements, because it is a big deal to enter into the agreement and you have to pass legislation to remove yourself from the agreement. So, you know, there's a lot of moving parts there.
Thank you, and appreciate the candor about the compact. It really helps when we have a good understanding of like where folks are at that have influence on the policy, that like, hey, you know what, we're gonna wait and let some of these things play out a little bit. Surely there's like new funding coming California from federal broadband investments. How should California be thinking about the funding to expand equitable access?
Yeah, thanks so much for that question, Mike. Yes, absolutely. California has made many investments in these past few years, particularly for broadband access. So in 2021, California made an over $6 billion investment in broadband and closing the digital divide. And the investments continue with new federal dollars from the National Telecommunication Information Administration, so the NTIA, the acronym, that are coming to California to build on that work that's been ongoing these past few years with the creation of the State Digital Equity Plan, led by the California Department of Technology. There's a grant from the NTIA that is currently open to apply for. It's the NTIA Native Entity Digital Equity Capacity Grant. That one's specifically for Native entities. Another one was the NTIA Competitive Grant Application. It's a federal grant application applicable for any and all states. However, that application period has closed. But we do know that there were more than 20 California-based applications that were submitted for this competitive grant. So they're waiting to hear if they're approved. And then another program that will be opening soon is the California Digital Equity Capacity Sub-Grant Program. And the sub-grant program will use funds to fund entities and coalitions to conduct a number of activities. And these include developing and refining local digital equity plans, provide localized digital navigation services, targeted device programs, and even workforce training programs. Currently, there's a public comment period open now until October 29th, open to all Californians to provide comments on the program draft. This is a real opportunity for stakeholders to provide feedback to the Department of Technology to shape how the structure, the rules, and the requirements for the subgrant program will be before it's finalized.
If we can, we'll provide a link for that at some point. Maybe the folks behind us. Oh, look at that. Amy Durbin's on top of it, folks. Yeah. So I'd like to thank you very much, Shirley. I'd like to bring the whole group together so we could do our just a group Q&A as an entire panel. So I guess I'm going to stick with Shirley and have other folks also weigh in on this. AI is at the top of everyone's mind. How does your org or the office approach AI from an equity perspective? And are there any particular bills this year that you're watching or were watching or anticipate?
Yeah, I can go first, Mike, since you called on me earlier. So AI clearly offers promising prospects of wider healthcare access and succinct modernized operations. However, AI is nevertheless a new and evolving domain that requires further research on its concerns and true impact on healthcare delivery. AI algorithms are reliant on inputted data for training, and biased data can be inherited by AI health algorithms, perpetuating and further exacerbating health disparities and hindering access to health services if not properly addressed, especially for vulnerable and marginalized communities. So ensuring diverse, representative, and holistic data sets is crucial to developing AI systems that work effectively across different populations in California. In addition, there are ethical considerations such as patient privacy, informed consent, and the responsible use of sensitive health data. Safeguards must be established to protect patient rights and prevent the misuse of AI technologies, but AI can truly play a pivotal role in promoting health equity. However, those careful considerations of ethical, social, and regulatory factors is essential to maximize the positive impact of AI on health equity.
Thank you. Would anybody else like to comment on AI? Before you do, I'm thinking about just how important even the discrete data elements are in all the records that we keep. I know in the past, working with several EMRs and quite a few organizations, that just even reconciling and validating the data that we collected on patients and even billing data, we had to go through several iterations at each organization to scrub and clean it to feed whatever system that we wanted the data to land. So yes, Dr. Glassman.
Yeah, maybe just another perspective on, I agree with everything that's been said about the need to be careful about what it is, what the black box AI, where does it actually get the information from, what kind of information did it digest in order to spit out what it's spitting out? And so I think maybe just one way to think about that now is that, just to underscore the fact, which I think everyone knows, but the fact that the licensed professional is ultimately responsible. And so I think AI actually is providing tools that can help make healthcare more efficient. The example I just talked a few minutes ago about the school-based assessments, that uses an AI system. Actually, if anybody's curious, you can go onto dental.com and you can see a free version of that system where you can take photographs of your own mouth and you'll get back a report about basic oral health conditions. But ultimately, the provider has to still be responsible. You can't just accept what the AI says. So I think these are better characterized often now as decision support tools. I'm a little concerned that some people are thinking that they are more than that. I don't think we're at that stage yet. So I think it's an important thing to underscore.
Yeah, those decision support tools, I'm glad you mentioned that, because I think they're actually going to morph into, in my mind, like an AI. I think people are just going to blend both of them at some point. And even in those decision support tools that exist now, I think they're baking in a lot of AI capabilities. So I think we're at this weird kind of blending and mixing of tools. Anybody else AI related kind of question before we shift gears a little bit? Nope. Okay, I see. All right, folks, are there any additional policy gaps in Medi-Cal or state law, and generally speaking, that you think continue to hinder access to telehealth in California? Anyone?
I mean, I feel like I kind of answered at the end of our initial session, but I'll just add, I think it's as access continues to grow and we continue to adapt to more folks accessing telehealth, little hiccups will come up in policies because those policies, and I'm referring to Medi-Cal policies here, were built around a traditional in-person mode of access to care. And so just something that I'm kind of anticipating is that, as we continue to move into telehealth as Planned Parenthood and as our patients move into it, little quirks and hiccups like, what can be mailed to a patient or communicated via telehealth and whatnot, those will need to be addressed as we go along. And hopefully, as long as we have the baseline coverage, those should be much easier problems to solve.
Yes, Dr. Glassman.
Yeah, maybe just one other thing. Maybe it's a little bit of the elephant in the room here, which we haven't really mentioned, which is that, and I understand it, that in people who are providing, making particularly Medi-Cal policy, often the big concern is fraud and abuse. And I remember I said earlier that I was in the Center for Connected Health Policies Coalition even before it was called the Center for Connected Health Policy. And one of the very first topics that came up in one of the very first meetings I went to was concern about fraud and abuse. And if we start to use this crazy new telehealth technologies, isn't there going to be rampant fraud and abuse? And I think if you're actually using the technologies and you fully understand it, you begin to realize that it's actually no easier to commit fraud and abuse using telehealth technologies than it is in person. But I think somehow there's some kind of assumption that that's going to be easier or more likely to have fraud and abuse using telehealth. So I think it's a myth, but I think it's something we need to continue to raise awareness about. Certainly, it makes sense for the Medi-Cal program to be concerned about that and to try and produce guardrails. But I think sometimes they get overdone for reasons that are actually not valid, that are really not any different than the kind of guardrails you need in an in-person environment.
It sounds like you're encouraging folks to use sounding current data or sounding current information. Just in general to the group, like how do we keep the drumbeat of incorporating and integrating telehealth into healthcare? So you're not calling it telehealth anymore. It's just part of like a delivery model. And, it's a hybrid. Really, it's not always in person. It's not always through some virtual mechanism. So you use it when it makes sense. How, if you want to emphasize any other points that you've made thus far, great. But how do we, as a group and a community, keep pushing forward?
I'll say for Planned Parenthood, in my experience with advocacy, something that can be really powerful is the narrative of a patient's story, a patient's experience. I love data and research, but it's not always the most compelling way to illustrate a problem or to emphasize the value of something. And so I think as we continue to advocate around telehealth, thinking about how we can uplift the ways that it's specifically and directly improving access and outcomes for patients in our communities.
I can also add on to you, Kelby. I know a lot of the work that ITEP's done, at least this past summer with our regional equity collaboratives, was really looking into local on-the-ground efforts about how to address the workforce shortage that's happening in California. And telehealth is a means for it. It's not necessarily they're going to get rid of in-person visits or anything. It's just expanding the choice. And I think there's lots of people who would love to have that option because one, telehealth offers them an opportunity to save on transportation costs. Transportation is a huge component right now. There's clearly a workforce shortage. We don't have enough PCPs. We don't have enough specialty physicians and allied health professionals there. But having telehealth allows them to kind of expand what's in their region to other areas without having to sacrifice taking off an entire day of work to go see a doctor or having to just ignore it. And that obviously worsens health outcomes in that scope. But the biggest barrier that we hear too is, besides the fact that they want to use telehealth, they can't access it because of the broadband issues. They don't know how to use the patient portal. There's also not necessarily live synchronous translations. Having a translator there for someone is a huge component. But the more that we can uplift, exactly what you said, Kelby, like uplift those like lived experiences to like state policy leaders, I think that will definitely help alleviate some of that, and also help address maybe some of the burnout that our existing workforce is feeling right now.
Thank you.
Maybe
So-
just one little note on to add on to what you just said, Shirley, is that I think in some ways it's helpful and not always part of the discussion to think about the question you just posed, Mike, in terms of in economic terms. And what I mean by that, this is sort of my MBA training, which I picked up along my very long road of my career. But to think about it in economic terms, where to highlight the fact that we do have limitations. An economy is what the whole world economy means is the science of dealing with scarce resources and how to best use them. And we have limited resources. You just pointed out, Shirley, we don't have enough, many kinds of things, primary care providers, et cetera. And we now do many things in expensive and scarce resource environments that don't have to be done in those environments. So that's just one example of how we can, number one, use our expensive resources and highly sophisticated resources more wisely for things that have to be done in those environments. If we can sort out and make available other ways of doing things, and we can certainly reach a lot more people, which gets at the equity issue. So I think anybody who's been working in the area of telehealth fully understands all those things. And I think our job is to be able to spread the word and help other people understand the benefits of this, and the fact that the system that we have now, which is primarily office, hospital, and clinic based, is certainly not ideal, doesn't reach far too many people, and is way too expensive for many things. And telehealth offers some really important alternatives and ways to address those issues.
Indeed. Indeed. Thank you. Just a comment and a question from one of our audience members, and we could try to cover a few of those now. It's interesting that the only bills signed by the governor this year from our long list were about AI, which suggests both which suggests both a public and political shift in interest towards AI safety regulations. How can we ensure we continue the momentum within telehealth policy and broadband access advocacy in the coming year to ensure any remaining gaps are addressed, especially in programs like Medi-Cal? It's interesting that AI has taken the attention of everyone. It really has. I'm just curious, before we kind of answer that question, are you using this in your daily, are you using any form of AI in your daily job or personal lives?
Anybody who uses a spell checker is using AI, right?
Well, yeah, then I've been using AI my whole life.
There you go.
I mean, I certainly use it when I'm going over contracts. How about you guys? And I'm curious if the audience, like if anyone wants to just say, hey, I use it too. But so why do you think the interest in AI safety? I know, Paul, you kind of covered it a little bit earlier, and so did Shirley, but is there a lot of fear there?
I think there is a healthy amount of skepticism. We always hear that California is leading and paving the way for a lot of things. In our latest fact sheet about AI, catalyzing AI to advance health equity for California communities, one of the things that we highlight is some of the federal initiatives that are being done. But, obviously this is an election year, so depending on like what the results that is with that administration, how that's going to affect those federal initiatives, I think Californians are really trying to pull together and really put their heads together to figure out like how do we safeguard things for Californians. California leads the way on a lot of things, and I think this is very typical of California to try to do this and stay ahead of everything.
Funny that you say that. I spent most of my career on the East Coast, and we always looked to see what California was doing.
Yeah. For Planned Parenthood, our patients' privacy and confidentiality is obviously a priority, and as the health system continues to evolve in technology and in some ways catch up with technology, that just only grows as an important focus. And so with health information exchange and EHR, that's long been a conversation. I think AI adds another layer onto that, and we have to ask questions about how data is being pulled from patients, how it's being tied to patients, how it might be shared, especially across state lines. We live, at this moment in an unfortunate reality where healthcare is being criminalized in other states, and we have a responsibility to ensure that, our efforts to enhance healthcare with technology at the same time aren't putting our patients and our providers at risk.
Thank you, Kelby. Guys, this question comes up quite often about digital literacy, but I haven't really thought about it. And this attendee asks, how do you address the issue of digital literacy for async visits? And I think you covered a little bit of that, Dr. Glassman.
Yeah, but I can say a bit more about that. So I think that, it's an example maybe of kind of lumping some things together that don't necessarily belong together. So I'm assuming that the question was referring to a patient to provider asynchronous visit where a patient's in their own home somewhere, they want to upload some information to their provider. So obviously they would need to know how to do it. That's, I think, the literacy question. They need to have the technology to do it. They need to have the broadband access to do it. But that issue is a different issue if you're talking about asynchronous technology where you have a allied personnel or even a layperson who's gathering the information in a place like a school or a community center. There's many places in our communities or organizations where people go, particularly people who have need for other kinds of services, where that can be the place where they actually can connect. Either someone does it for them or they can do it themselves. So I think it's less of an issue than that question would imply. And in certainly the work we've been doing, where we've been bringing care to where people are by sending teams out, it's not the health professional who's going out, and sometimes it's just the school staff, or sometimes it's a community health worker, or sometimes it's a home visitor, but they're the ones that are providing the literacy, the knowledge of how to do it, the technology, the connections, so that the individual themselves or the families themselves don't have to have those things. So I think that question lumps some things together that shouldn't be lumped together, because asynchronous technology can have lots of use and reach many people without the individual themselves having to have literacy, technology, and broadband access.
Very interesting point. You're right. I hadn't thought about it like that.
I can also add in a little bit about addressing digital literacy. Maybe it's not specific for asynchronous, but could be. ITEP's done quite a few publications, and when we were talking about broadband and digital literacy, we realized that there are a lot of patient intake forms that people go into their PCP to put in like their medical histories. They've included social history now, education, all those components, but there's no section in those intake forms that asks, do you have a computer? Do you know how to use, patient portals or anything like that? So there's no screening questions that talk specifically about telehealth or asynchronous telehealth or any of those kind of modalities, but it's offered to patients without kind of context for it. So that's like one of our big policy recommendations that we've tried to elevate before, is that like we have these already screening intake forms for patients. If we can collect that information, that would help to identify like digital literacy barriers, any areas that they might need assistance. And then that's the kind of human connection that we can potentially connect them to a digital navigation resource center, or connect them with the community health worker or promotoras. They can be digital navigators, and especially since they're trusted messengers, they can also help bridge that kind of hesitancy, if you might say, for even engaging and using those as well.
You just reminded me, thank you for that answer about the screeners. I believe an author from Thomas Jefferson University Hospital in Philadelphia just published something in JAMA about those, like a screening tool that could be used in assessing a patient's or their caregiver's capabilities and how to use technology. If I can, I'll find it and then I'll send it to May and team so we could share it with the group. There was a comment from Michael. I hope you don't mind. I'm going to use part of your answer. Michael is an attendee. He responded to my question that I asked the audience. He wrote, I use AI almost daily to generate text, emails. So in case you're emailing Michael, everyone knows who Michael is. He might be using AI to get to communicate with you. Summarize his own meeting notes and interrogate documents. He uploads PDFs and other forms, and to get answers and reply to those documents as well. He adds a little bit more, but obviously, like, he's not the only person. I'm not the only person, and it is becoming more and more known, I guess, in everyone's life. So there was an earlier question too, and maybe Amy Durbin could address this, or Dr. Glassman. What constitutes a patient-provider relationship as far as Medi-Cal regulations go? I think the second part of that is it's just basically what constitutes a patient-provider relationship.
Yeah, I can chime in. I'm sure you can as well, Dr. Glassman. But yeah, I think whatever the modality is for the on-demand visit. So if the platform is using live video, then that would constitute an available modality to establish a patient-provider relationship for purposes of Medi-Cal coverage. So live video doesn't have those restrictions. It's the other modalities that are limited, and some have different exceptions.
Yeah, and I think maybe that sort of leads, I mean, you were talking, Amy, specifically about how it's addressed in Medi-Cal policy now, which is the fact that synchronous interactions count, and in some places asynchronous don't, although in dental care asynchronous do. So we've got that mixture of policies now. But I think the underlying idea is, and this is something that part of what we've been able to advance in oral healthcare, which needs to be spread across the rest of the healthcare spectrum, is that the idea of a patient-provider relationships is someone who's actually seen the provider previously and established a relationship. A relationship meaning they've had some care, they've got a record in the provider's office. And so, I think the issue that we're talking about throughout this, the theme that's sort of woven here is that when we first started advocating for where we are now in oral healthcare, that had to be established an in-person visit. So we had this crazy situation where we had the ability to send dental hygienists into school, keep the majority of those kids healthy at school. These were children who had really very little, almost impossible to get to a dental office. And yet for that to count or then be able to bill for that service, they had to have previously been in a dental office. That's how you establish the relationship, was previously been to a dental office. They saw the provider in person. Now you could work with them remotely. Well, of course, it just makes no sense to think about it that way. So fortunately, in oral healthcare, now that's changed. And so we have the ability to establish that relationship both synchronously and asynchronously. Right now, as you just said, Amy, some other aspects of healthcare, it's restricted to just synchronous, but really it refers to having previously had an interaction with the provider. I think we just need to open up all the methods of doing that.
So as the crew looks at 2025, what policy or funding opportunities are you looking forward towards? Think of 2025, and I think a few of you guys mentioned it, and it's okay if you reiterate or repeat it.
Yeah, I can go. So in this past legislative session, ITUP was actively engaged and participating in on-the-ground efforts to support Assemblymember Bonta's bill, AB 2239, digital discrimination of access. But unfortunately, it didn't make it to Governor Newsom's desk. But we're also tracking some of the other bills that were mentioned earlier by Amy. They were Senator DeRosa's bill, SB 1179, Affordable Internet and Net Equality Act of 2024. So those are kind of the broadband ones that we were tracking. But policymakers, we've already discussed this, are actively introducing legislation to regulate AI and deploy guardrails. There were at least 50 AI-related bills being introduced in the 2024 session alone. So I expect there to be a lot more in the 2025 session. We're tracking quite a few of them. We have our full list of bills that can be found on our website on our legislation roundup blog, but a few were mentioned earlier: AB 3030, SB 1120. Those were both passed, but we're also tracking SB 1047 that aim to set safety standards for large-scale AI systems, ensuring that these technologies are developed responsibly, as well as SB 892, which tasks the Department of Technology to create safety and privacy and non-discrimination standards for AI services. However, both of those bills were vetoed, so we'll be anticipating what is to come from policymakers in the upcoming legislative session.
Thank you.
I can mention something we're looking forward to in 2025, which is, I mentioned earlier quickly, this idea of this concentric circles model where you have the scarce and expensive hospitals, clinics, doctors' offices, and then you have health professionals in the community, and then you have non-professionals. I call it this concentric circles model. So we have just applied, we collaborated with some folks at the University of California in San Francisco to apply for a $100 million grant that would produce a large nationwide demonstration of this concept.
Wow.
I don't think we're going to get it because it's for many reasons, but we're going to continue to, that's one of the things on my radar now, certainly in our work that we're continuing to do, which is the idea of using demonstrations to drive policy. We're going to continue to look for funding for that, because I think this idea of a distributed system where you start to bring other societal healthcare, education, social service agencies all into a system where they're interconnected. We have the technology now to do it through telehealth technologies. That builds a healthcare system that can do so many more things in the current system, where you think about people who just have to go into an office or see a physician or a dentist in person. And so I think that, to me, is at least the work I'm going to do, that's an important direction for 2025.
Thank you. Well, let us know if you get that 100 million.
Yeah, well, you'll hear the champagne.
Natalie or Kelby?
Yeah, just personally, licensure mobility is something that I'm really interested in, and I plan on keeping to it, to keep exploring it, especially in terms of telehealth. I think people don't live the same ways that they used to, especially with COVID. We have a lot of people who are constantly relocating for maybe a few months, and we need to make sure that policies are working for not just patients, but also for providers. I didn't staff the digital equity bill. I think that's something that my office is probably going to keep working on. Assemblymember Bonta is very committed to increasing access to healthcare in a variety of ways, and clearly broadband is a huge part of that. So I'm happy to connect anyone with the staffer for 2239. But that's sort of what we're thinking about right now.
Thank you. We'll take you up on that. Kelby?
We'll definitely continue to advocate for asynchronous coverage across the board, and just in general reducing the inconsistencies in coverage, depending on what type of provider or what type of care you're getting, because all that does is add confusion for patients. So meaningful coverage and less convoluted access.
Yeah, because even when it's not confusing and convoluted because of regulatory and policy issues, it's still pretty confusing and convoluted from a consumer perspective.
Mm-hmm.
I like to thank all the panelists for all that great and very, very helpful information, and just explaining it so we could kind of, think about it and do something with that information moving into next year. May and team, would you like to take over here?
Thank you, Mike, and also let me extend my thanks to Natalie Pita, Kelby Lynn, Shirley Lamb, and Dr. Paul Glassman. Also to our wonderful moderator, Mike Curlin, for the great job that he did. Just a few things before we close out our webinar. Please note that the California Telehealth Policy Coalition is having our annual meeting next month. It will be in Sacramento on November 19th. It is an open meeting, so you are welcome to attend, but you do need to register just so we know who is coming and we have an accurate count. Next slide, please. Additionally, I would also like to thank our sponsors once again today, the California Healthcare Foundation and the Center for Connected Health Policy. Without their support, these educational webinars and legislative briefings cannot happen. So thank you to them. If you have questions about the California Telehealth Policy Coalition, please contact any of the people listed below, myself, Amy Durbin, or Stephanie Thornton. And I would also like to thank the staff who helped pull this legislative briefing together. That's Amy Durbin, Stephanie Thornton, and Kevin Quach from Blue Path Health. Thank you, folks, for all the work that you did. And also thank you to all of our attendees for being here today. It looks like there's still more work we need to do here in the state in regards to telehealth policy. So we hope everyone will join us on this continued journey and keep in touch with the Center for Connected Health Policy and the California Telehealth Policy Coalition. Thanks, everyone. Have a great day and stay safe.